Please start, sir. We are live.
A very good evening, all the distinguished delegates and today's eminent faculty, Dr. Prashant Advani, sir. This evening, Zydus Life Sciences would like to thank you all for your participation on this evening, Saturday evening. This is Clear Talk. Clear Talk is one more facet of Unite Against Dyslipidemia. And the recent development in the management of dyslipidemia, that is bempedoic acid, and the Clear Outcomes trial, which was presented in recently conducted American College of Cardiology. So we have a hot topic here, and we have one of the best faculty to give talk on bempedoic acid through the lenses of Clear Outcomes trial, none other than Dr. Prashant Advani, sir. Would like to give a small brief introduction about sir. Sir is a consultant clinical and preventive cardiologist at Advani Heartline Raipur. He has more than 15 years of experience. He is affiliated with many membership, few of the membership which I have noted down, but this is a small brief introduction about sir. He has a vast experience. He has given so many lectures at national and international forums. He has been a great orator, and we are very fortunate to have you, sir, here on this evening talking about Clear Outcomes trial. And over to you, sir. Without wasting much of your time, I'd like to hand over session to you.
Yeah, thanks, Satish, for the introduction. And I'm starting share from my side and just be around in case. I think I'm full screen now. No, yet slideshow from beginning. That's okay now.
Yes, sir.
It's changing. So good evening, everybody, and yet another webinar. Though we have started physically, I'm doing so much of physical now. Say once in 14 days or once in a week. But then this is another platform we learned in the pandemic time, which will always be there and gives an opportunity sitting wherever in the part of the nation we can communicate with each other. So coming to the crux topic that I've been delegated this time, of course, we have listened on this topic on various times during this pandemic time. This is coming from host company Zydus, a very responsible company, a very kind of an Indian MNC, CLEARTalk Meet. So I am appreciating the word clear because clear outcome and clearing LDL particle, clearing the circulation through it, and focusing on a molecule bempedoic acid, which we're hearing this noun for now a couple of years. And I'm also gaining experience in prescribing with how best we can use this in high-risk CV patient in India. I'll give a certain case example, and I'll come to the crux of preventing the heart events in a high-risk cardiovascular patients, and which I see day in day out in cohorts, and most of them are younger. And I emphasize to all delegates attending here or my co-faculties here that it has to be extrapolated to the patient, like it has to be transported to the patient. I'll show the data even in the West, the penetration of these guideline-directed drugs and in a proper, in all the realms. I'm not talking of lipidology, in diabetology, in overall cardiovascular, metabolic, cardiorenal medicine is very abysmal, more so in India. So LDL lowering is a very, very important component of preventive planning of any high-risk individual, right from the middle age onwards. We all Indians, including me, are at a higher risk of major adverse cardiovascular and cerebrovascular events. And we have now novel molecules in industry globally. And putting our Indian industry is replicated at a very reasonable prices to Indian setting with the same quality. But we have to see that we have assigned a patient and we're given the requisite targets, the designated stipulated targets, like for LDL target for that individual, the HbA1c target for that individual, the blood pressure target for that individual, other things, the dietary target, the waist circumference target, the fat content target. So that's how you reduce the risk. Any patient with a given syndrome and comorbidities or functional structure it presents to you, we have to be visually smart and erudite to assign and designate a drug requisite for his requirement in order to prolong his life, quality and quantity of life. So that's here, Dr. Prashant Advani, a clinical and preventive cardiologist, and I'm going to re-emphasize lipidology in general in a very, very swift manner. And I'll delve back into the recently released, because I was already aware. I was following Clear Outcome. I did Clear programs when it was approved for LDL lowering, but now Clear Outcome is, for the want of the outcome trial, it didn't like it was not being promulgated by the industry, but now it has a good feather in its cap, an outcome trial coming after statin, which is positive. I'll come back and I'll set the context. So statins, you cannot function globally across Atlantic, wherever, irrespective of the race, without statins. Statins are the cornerstone of it. But very simple. Statins, maximally tolerated or high dose. You have to administer any patient for high risk primary prevention or secondary prevention, statins. Then many patients, the thing is that also in India, insufficient, suboptimal response to high dose and HIS, high intensity statin, HIS, the abbreviation, inability to take effective doses. And there's so much of statin phobia, thanks to the social media or anywhere, like the people are ill-gotten. Even the most educated people talk very stupid question about statin. So statin-related phobias, inability to take effective doses. Additional option that complement maximally tolerated. I'm going to assign an LDL target to that individual. I must tell you, they are so low. We have to go very low, because laden with risk factor Indians are. If you lower LDL pharmacologically, they don't do it non-pharmacologically. You're doing a great service on them. They themselves don't do it. So it's a pill solution for the risk factors. And bempedoic acid has come handy, because in India, I'll tell you that we are still economically constrained, and insurance is an issue. We need cheaper molecules because we still can't utilize the fancy things. We talk in conferences, so many things. But then again, in a real world scenario, the situation is totally different. So PCSK9, serines, and so many molecular antibodies out of question in India. So we need good, reasonable molecules coming from good company like Zydus, and that has to be applied to the patient. So I need a statin for my patient. We have all so many risk factors, irrespective of primary or secondary prevention. Lipid lowering is the cornerstone. Hypertension is corner, HB, and lipids are by statins. So statins, any drug that come after statins, it's not going to replace statins, it's going to supplement statins. So here I am for incremental LDL lowering over and above statin usage. If you are not tolerating, I'm actually replacing statin because they're not tolerated. After they're suboptimally responsive, I'm adding to the statin. So this is how I've been aware. This is just very simple. Lipidology is very simple. So known atherosclerotic disease, how you are atherosclerosis in India, we have two ways to risk define. To prevent atherosclerosis, it could be subclinical, clinical, or very dreadedly manifest atherosclerosis. So you have residual cholesterol risk even after control, giving maximum tolerated to the statin, but LDL is still hovering above the designated target for that individual. You require additional LDLs. You have residual inflammatory risk. You have residual oxidative risk. You have residual thrombotic risk. Now you have residual sugar risk, metabolic risk. We have all these risks. Risk for ASCVD. And this is how it's happening. And in India, even after, say, even if you control LDL, there is still residual lipid in terms of coming from remnant particles, high triglyceride, and ApoE particles, or particle size. And this is not the crux today. And then if you are not controlling LDL to the designated target, you are just doing no service to the patient, because lipidology now is hovering around India, especially in LDL and then LDL remnant particles, because the cholesterols are attached to these triglyceride-rich laden particles too. And what is more important is that exposure to the LDL, which we always forget. There's always a legacy effect in chronic disorders. So you have a bad legacy coming right at the beginning, as you are getting adolescence and going. So you're missing out on these tiny rises of LDL levels or LDL particle size and circulating quantity of LDL. So you're exposing your endothelium to bad legacy, even if you control later on in the future. But that's ill-gotten learning by the endothelium is a very counterproductive in future. It destabilizes the plaque. Prolonged exposure is a big thing. Mostly in familial hypercholesterolemia, which also we have heterogeneous variety in India, which I think that we probably miss out many a times. And we have to see a global risk, not only LDL. one wing, controlling one wing, that too we don't do efficiently, but then not controlling one wing is the 1/5 or 1/7 job done. So, and there's so many statin trials, but I'm not going to delve here. Statin trials in primary prevention, secondary, I must have done tons of talks on these things. I'm not going to bore you with this. LDL, lower the better, lower the better. Each 1 millimole down, and your vessels are eased out, your plaques are dried up, that are stabilized, the necrotic core goes down, the fibrous cup thickens. So we know that events are down when you have even 1 millimole LDL around close to 38-40 milligram% down. And we have targets coming down. We learned that as time is, we are still learning. We scientists are learning. No. This is 115 is very high. 60. When I was in MDs, 140 was fine. But now we know that in this is ESC itself is reducing the target. ESC reducing. But now, when I say, okay, I've achieved 55, is it enough? First is concern is, do all statin user are given a statin high dose, say Atrova 80 or Zyrova 40, job done? Probably not, because I have to see whether he has reached. How to achieve that? If he has not reached, then how to achieve? So this is the crux. First, I have to designate an LDL target. Then I have to see he has achieved it in 1.5 months, maximum 3 months. And if in AC situation, I don't have much time. So Da Vinci study in Europe, in a real world cross-sectional observation, they say in Europe, the most of them are educated, yet the penetration of the statin deserving patient are not receiving statins first. And then even if they're receiving higher, they're achieving their target. Only 20 to 30% see in India, if it's in Europe. So we are only managing tip of iceberg. Hordes of people are at risk, swaths of people are at risk. So 50 to 80% of patients don't achieve LDL goal despite statin therapy. 30% are intolerant. In India, 20 to 30% are intolerant. And you have a concern of new onset diabetes, which is also a concern because lab reports nowadays, people are getting in and they are all skewed up. They are not landing up in the gross diabetic state on between, and you start studying based on LDL, and these guys might shift code across the line to become diabetic, NOT, new onset. This is a concern. So statins have flip side too. Statins are cornerstone, numero uno, quintessential drugs in lipidology, but they have their flip sides. And even after statin, there is a residual risk. See, in the secondary prevention, huge residual risk. So just by prescribing 0-20, we are not done. We have to see that global risk, and that we have to see that lipid wing of the global risk, which I'm at that for the timing, putting my attention to. Have I achieved that? So residual risk of incidental vascular events or progression of established vascular damage persisting in patient treated with current evident base. So residual risk still high. So we have to be dynamically risk assessing the patient in every visit, which I do in thousands of my patients. And then this is something which came first and from ASA, how to risk assign, how I know the risk, because I just visually, as he enters, I talk for 3 minutes and I know what is the risk. Most of my patients are extremely high risk, very high risk, or high risk. Nobody is moderate or low, barring some outliers. So we all Indians are extremely high risk, very high risk. If you have an event or an established ADVD, you are high risk. In diabetic, at the time of diagnosis, there are 2 major other risk factors like dyslipidemia or hypertension, central obesity. And then as I say, subclinical CVD or subclinical heart failure already there at the time of diagnosis, and 2/3 of the patients. So this is an enormity of the problem. And all these guys actually require, this is how it is stratified. This is ESC, this is ESC, and this is our own Indian guideline, which is very good. Indian, how do you risk stratify, risk factors, and then establish. So most of us, or most of our patients are very high risk, very high or extremely risk. One event, then recurrent events, in spite of LDL below 71, another event, thanks to their lifestyle, and then so many intangible risk factor, pollution, stress, not taking food, vegetables, this is another one. And if you go for that, which I'm now doing, is calcium scoring, and I do my CT angios, and these guys have sub-intimal plaques, and it's not obtrusive luminal narrowing, but then there's still a high risk of SCDs. We know that all. And high intensity, even if they tolerate, or if they administer, they lower the burdens. To higher risk of how low adherence, because high intensity statin, HIS, as it requires some amount of medicine knowledge and tackling the flip side, the adverse event, the side effects. So tolerance is an issue, and if you go down by the dose, and the MACE risk goes up. Ultimately, I want my patient to endure the target assigned to him. And as we know, because these guys which are quasi-healthy, they're good. They only have normal risk, but they are at high risk or extremely high risk of certain events. Their events are coming from non-obtrusive plaques, and these plaques are very LDL respondent. And so what do I do? How to achieve? How do I do even if they have not achieved their LDL goals in spite of 20 to 40 mg of Zyro or of 40 to 80 mg of Adrova? So what do I do? So there have been so many trials, statin, most of them is statin trials. And then now we know from 2015 onwards, 4-year Odyssey outcome, alirocumab, evolocumab, these are pieces of novel molecule. But at my level of the maximum cardio-diabetic patient, I can only assign 2, or I could only assign 2 or 3 on Repatha. But this is out of question because as we in diabetes, when we talk of GLP-1, GLP-1, then in the real world, it's a different. I'm talking you giving it tips and tricks and real. And the want of additional, we know that ezetimibe does help statin over and over. We can just start with, but then clear outcome, which was all pain. And then now it's released in 2023, the 4 and 5 years of trial, which I'll delve for a couple of slides in subsequent part of my presentation. And we know that what works, what doesn't work. So ezetimibe, PCSK9 does work over and above statin, but fenofibrate and all niacins don't work. And all extended-niacin, laropiprant, and all these things. And so many, still there people are after CETP inhibitors and their HDL raising strategy, they have still not given up. But that's not the point here. Still we are focusing to bring patient to a designated, lower the LDL in India, brings patient to the, and how do I do that? You have, the moment you have a clinical ASCVD in any which form, prior ACS or prior, we know that now we say chronic coronary syndrome. Nothing is stable in the realm of clinical CVD or heart failure. Something is smoldering inside. Either plaque is stabilizing, destabilizing, some inflammatory or necrotic component, intraplaque temperatures are changing, the migration of smooth muscle is up in there, the thinning and thickening of it. So nothing is stable in the realm. So we have to go all guns blazing, and we have to apply all this clinical and preventive science to the patient's benefit. And we have to apply, and we bring down to the resistance. As I said, the Lipid Association has given a target of less than 30 or 40, who are very extremely restless. I bring them down to 30. So somebody who's on a 40 mg rosuvastatin or 80 mg Adrova is still hovering around 52. I am not satisfied. This guy, I want him to come down to 30. If it's not able to, what do I do? So then you have to have CSK9, ezetimibe, and then bempedoic acid helping him. It helps like it to become a power couple if you just utilize them with safety. And I'm just going to tell. So optimized statin therapy, of course, residual risk, triglyceride rate, we have future molecules coming, and all this, we know that is LDL lowering pathways of PCSK, how they work. And now bempedoic acid, because this is an oral molecule, very simple, just a pill, and I must be having 30, 40 patients, yeah, all good in terms of reaching to LDL goals. And available as Nexletol and Bemdac here, lowers LDL, so many safety and efficacy study. How does it work? Very simple. It works 2 steps above the statin pathway in liver, and it's a prodrug goes inside the liver, requires CVCL, one thing, which to make it active, which is not available in skeletal muscle. So no risk of any skeletal. So myopathies and myalgias and muscle pains are not a bugbear any longer. So somebody who's getting annoyed and pestered by statin therapy can rest easy, because this guy is very, very muscle friendly and hardly any risk of new onset diabetes. Of course, it has its flip side coming from Clear Outcome trial. I'm going to delve on it. So ACL, heavy-citrate lyase inhibitor, 2-step off, and then it goes to HMG-CoAs inhibitor, and then it becomes the similar way. So that you go 2-step up in the same pathway. And this is how it's here. I've given this slide to make it easy. Inhibition of ATP citrate lyase, and then it requires an acetyl. This step is a 2-step up from HMG-CoA, which is a key step in statin pathway. And after that, there's a downstream cascading pleiotropic effect that come out of HMG-CoA reductase inhibition. We know that how statins are pleiotropic and anti-atherosclerotic and his preventive. This is we all know. But it's a 2-step up. So there was always a concern after it was, or a speculation that it is going to work in the same pleiotropic way as statins. So this, and then they can all come in a synergy. And ultimately, and there's an overexpression of LDL, the recycling is in the LDL receptors, and LDL levels go down. And this is the same way that statins function. And overall effect, 15 to 25% reductions are not as robust as statin per se, 50%, up to 50% or beyond from statins, most from rosuvastatin. and atorvastatin. 15 to 21% reduction in non-HDL. Of course, non-HDL also goes down. Apolipoprotein B, obnoxious apolipoprotein B, which penetrates across the valve, HSCRP level, and this just happened in 1.5 months. This all came from the previous year's study, the CLEAR program. Safety, most of them were CLEAR program, Harmony, Wisdom, Serenity, Tranquility. They all were the safety and efficacy programs. And they were nominal, a very kind of a placebo compared side effect, nasopharyngitis. I have not observed any of them. Uric acid, not unless you have an active gout. This is not a concern at all. Slight increase in creatinine because it goes in kidney, 650 to 70% goes from kidney, and then a BT inhibition. But again, that's not a concern at all. Compelling to stop this drug because of this concern, I think hardly. Even in CKD, it can be given. So only thing is nasopharyngitis and watching for gout related thing, which is hardly a concern. So I give this woman, around 50-year-old woman, type 2 diabetic, like this is a run of the mill. We see many 20-25 such patients daily, and this she has been told her cholesterol is very high. So diabetic dyslipidemia, or what we call atherogenic diabetic dyslipidemia, and this she's around 49-50 and must be having other risk factors. So our LDL should be no prior event I mentioned here. So LDL should be around 50 or say 55 or even 40 is fine. But this lady received rosuvastatin 40s or over 40, metformin, telmisartan, and Claritin. Of course, she's a high risk woman with type 2 diabetes of certain duration and dyslipidemia. So LDL 130. No, I 150 or below. So this, and we know that this residual risk even after 40 mg and it drops to only since it was coming down by only 40 milligrams. So it's a less than 50% drop, which is very common in a statin treated patient in India. So what do you need? And this is residual risk persisting. You have not done away with just prescribing, and you have to follow it up, how he's responding. Of course, non-pharmacological amendments are to be reinforced, but patients don't do it irrespective of time or exhortation that you spend with. So for patient was prescribed bempedoic acid after waiting for 1.5 months something, and then she drops further and comes down to 52 eventually. Also, I would have given ezetimibe in addition if it has not been done. Another person with hypertension, diabetic, complaint of pain in legs, as he has been started with any of these 20 mg rosuvastatin or 10 to 20 mg with so low dose of, yet he has pain in hands. So every time 10 to 20 was done and he had a pain. So it's very clear, you stop the statin, pain goes away. No myopathy, no grades, the grade rhabdomyolysis something, but muscle related statin associated muscle symptoms, SAMS, SAMS. These guys are very common in India. We do that, and we also see for other reversible thing, vitamin Ds and thyroids and other things. Of course, we know that. But this guy who requires actually diabetic have statin or LDL lowering, but you can't do it, even an iota of statin not being tolerated. So here in statin intolerant patient, before clear outcome, there were certain trials in many ways, and then the certain studies in regional things, and they said that if you write bempedoic acid, they lower their LDL without much ado, and there were muscle related things. So these were all, but then for want of a trial, it was still awaited. So finally came clear outcome. Clear outcome is an outcome trial. So it's a big thing. Lead broke is 2020, just recent this year, and everybody was looking forward to it, and the hall was resounding with cheers. Stephen Nissen, who is a good lipidologist and a good clinical grammar, and we know Steve Nissen, and from Cleveland Clinic. He's this as genius, and of course, remember the blade breaking speech over there, and clear outcomes from that. A very, very simple trial. You are statin intolerant, huge patient across the globe, 14,000, 7,000 each in each arm, placebo over placebo, and this was the background. Patient was statin intolerant, and which occurs 15 to 20%. ATP citrate lyase inhibitor, as I showed you, how it works. But there was no outcome trial. We know that it does lower LDL and it does support statins, but what are the outcomes per se if there were no statin? So this was a landmark trial in that way, and pretty standard. They actually had extended primary 4-point MACE, including coronary revascularization, apart from the pretty standard non-fatal MI, non-fatal stroke, and cardiovascular death, and also hierarchical testing for key secondary, the three component MACE that we have: standard, fatal, non-fatal, coronary revascularization, fatal, non-fatal stroke, fatal, non-fatal MI, cardiovascular death, and all-cause mortality. And the outcome was it was rather positive trial, and overall the demographics of the patient, the most of them were around the median age 65, LDL was 140. So see that in an era we used to have when 20 years back 140 was considered it's not that bad, so-called. Now we know that 140 is terribly high. At borderline, we see patient coming in 190 plus, which is actually going in the realm of FH, and we don't take it light. Anything above 100 in India is not good, even if it's for primary prevention. And so, and then the GFR was around stage 2, 60s and plus, and these most of them are 70% up under secondary prevention. So high risk cardiovascular patients, and 45% were diabetic, and 20% were not. And also very interestingly, some patients were receiving statins. In the sense, so if you have statin intolerance and you are a high risk ACVD patient, you want to give some statin, say 10 mg every alternate day. So not approved by the guidelines, but some tips and tricks somebody was receiving. So these guys didn't stop. So around 20% in either arm, placebo, and around 1,600 patient here and 1,500 patient over there were receiving some amount of statin in off-label kind of usage, 10 mg 3 times in a week or something, because these 4 years of follow-up, 5 years of follow-ups, they wanted some LDL. Or also somebody was on PCSK9 inhibitor, ezetimibe was around 11%. So ISO matched LDL levels, and then you see the difference. So with a 13% reduction in 4-point MACE. So this is a better depiction here. 4-point MACE down by 13%. Kaplan, I removed the Kaplan. We're so crowded here. So Kaplan-Myers are on this side. This is kind of a good pictorial. So 13% down, 4-point MACE, 3-component MACE is down to 15%, MI by 23%, which is great. So the component analysis, if you do, so 23 divided, as I said there, if you lower the LDL in a high-risk patient, it actually comes by the plaque stabilization. So MI is a very important. So it does do something like statins, of course, albeit in a moderate way, but it does do it, because the same pathway, 2-step up, we cited lies, and if you marry it with the statin, it becomes a power couple. So coronary revascularization was down by 20%. So medically, it's eruditely, smartly, aptly, if you manage, actually the patient can remain out of hospital very stable, even in high grade CCSE. If you have mid LAD 90%, LSD 80%, and you are fair enough in your class 2 anginas, and then your anginas dissipate if you're a good proper angina. So, and most of our patients, 50 to 60%, are CCS patient. Prior ACS, you come them out, make them out of it, and after 2 or 3 months, they become CCS in a nicely manner, unless you have proximal lesions or LM lesions, which most of us patients go for revascularization. But then what I'm alluding to here, in prevention at every level, every step, prevention, which actually goes in a long way. Mechanical approach. So the technician in the doctor, in the physician like me, should be behind. The clinician should take the forefront in order to risk assess, triage, in an algorithmic way. And this is no great science. If you do it daily, day in, day out, a patient, huge patients, and you will have a visual approach to risk assign a target, and then you choose the molecule. So to assign a target at the inception, as I said, and then choose the molecules. Very simple. Clear outcomes had also CRP reduction, so, and inflammatory. So it does work like statins, and a bit in a moderate way. But that's a trial clear outcome in statin intolerant patient. But most of them are very high risk. The primary prevention people were high risk prevention people. They had the conglomeration of risk factor, clustering of risk factors. So how did they conclude? Becomes the first ACL inhibitor, ATP citrate lyase inhibitor, and first oral non-statin to demonstrate a statistically significant reduction of MACE, 4-point MACE, coronary revascularization included. This is great. And at a high risk of CVD with documented statin intolerance and elevated LDL-C. So this is a good feather in our armor. This is a good in arsenal. We have enriching tool to use before embarking on PCS. And of course, in US, insurance does cover PCS because they use in upstream than this. But I think in there also they are picked it up. So how I conclude that Bemdac acid an effective alternative for statin intolerant patient, and it does reduce the other pleiotropic markers like HSCRP volumes and good. There was around 13% 3-point MACE reduction and 19% revascularization reduction. So it's a small molecule, and there's additional 15 to 20% LDL reduction over and above statin, or by per se it can do 25 to 30% statin intolerant patient, and very safe. So it can marry with statin, or it can do its job without statin, albeit in a bit of moderate way. And safety and efficacy for cardiovascular reduction has already been tested. So we are entering in a new era in 2023, the middle of 2023, and we have so many drugs, so many molecular antibiotics, and also not only we are targeting, we are also seeing the residual risk. We are seeing a residual inflammatory risk. And if it is lipid ramps, we have the triglyceride as a risk. Again, more so in India, we know that how triglyceride, and also from the host company or novel molecule in India, seroglitazar, lipaglyn, that we also using, and probably indirectly we have no, but then practically we see that the outcomes are better. So and so many for familial things which we are not going to discuss here, like PTL3 antibodies and buprenorphine, and this is not a lipoprotein A reduction, because lipoprotein A is a very lighter protein, little a, it's very thrombogenic. But then again, you have to risk assign, you have to see LDLs come to the goal, and then use molecules in a sequential way. Statins, patient army up to statin guy. No, this is over and above. Again, statins are still the king. Statins, it's hegemony of statin never going to be challenged. I cannot function without statins. Most of my patients tolerate statin. Of course, this is for statin intolerant. Statin hyporesponders, not non-responders. Non-responders are hardly any in India, but hyporesponders are many. And then you have to choose assign an LDL target. Oh, this guy Shakil has come with an event or LDL target. I send 30. So I'm making. I'll go on guns blazing. I go LDL chase on an LDL chase in 3 months to bring him down to 30 or below. And we know that a suboptimal, very low, it drops at a nadir of around 18 or 14 is without any concern. Nuance diabetes, hardly any if you are listening, or neurocognitive decline. And then of course you are going to see other things too. Overall global cardiovascular risk. So this is a new algorithm. You have to risk assess and then use molecule. This is how I think I've positioned here ASCVD patient or at high risk of events, ASCVD related event, ACSs, or so you first to high HIS, high intensity statin. Then if you add ezetimibe, you high intensity statin, HIS, his 50% reduction. That expectedly, putatively, it should happen. It may not happen. If you add ezetimibe, then you have 65% total reduction of LDL from the baseline. You add bempedoic acid, another 70. So you have gone from the baseline to 75% now. But still you are not at a target, then you have PCS. So in India, I will go like this, not PCS can preceding bempedoic acid. Or you can just start with this. Somebody has a very extremely high risk, LD is around 162. I am not going to wait for the sequential. I might start right with the rosuvastatin and Bemdac combination right away, right at the beginning, at the inception, and can take a call later. But then offer him an LDL lowering effect because it pacifies the instability that happens during the plaque ruptures and disruptions. In familial hypercholesteremia, I've seen when I have around 11, 12 patients, but then again the same sequence. And statin intolerant patient, I have around 17, 18 here out of thousands of patients on. So you statins are out here. Now you have Bempe and ezetimibe combination in order for the patient to reach to bring them to their target, stipulated target. I'll assign them a target, and also I'll see other glycemic targets and blood pressure targets, their inflammatory targets, their lifestyle target, their body weight target, BMI target, their waist circumference target, their functional capacity. So this is how residual risk and all RAM to be addressed dynamically So assigning once is just a job. Good initiation and then enduring with it. And I want to endure my patient of these ultra low LDL targets for a longer time. So this is how it happens. So bempedoic acid is a good component for over and above or incremental LDL lowering, and pairing it with statin intolerant patient. This is the only option. And what's the only option? Oral pill with outcome results. And worsening hyperglycemia doesn't happen with it. So bempedoic acid helps in additional LDL lowering, can be added to patient who are intolerant. So again, I'm recapitulating, I'm reiterating, because this is the RAM. I'm horrified when somebody asks me, now statins have a replacement. No, statins don't have a replacement. So get to the goal. This is my slide. But I think it's visually impressive, because we have to, by optimal treatment as per the risk of the stratification, because certain benefit outweigh the risk. And you have to, bempedoic acid is a good tool. And believe me, if you use ezetimibe, high dose statin, his ezetimibe and bempedoic, or forget ezetimibe, if not acute bempedoic and this statin bempedoic patient will be on target. Would lead, of course, ensure the lifestyle amendment there. So I thank here. Probably I've done it on time. And should there be anything, I don't know, how would I know, because it's not an interactive one, the question answers. Stop share.
Thank you so much, sir. Thank you so much. This was a really nice and wonderful presentation. There are a few questions online. I would like to ask those questions one by one.
Just a bit louder, Satish. Yeah, I'm not. Please.
Yeah, there are few questions online.
Yeah,
I have on my screen. So I'll be asking those questions one by one. So the last statement of yours, like get to goal by optimal therapy. So there's one question about it. You talked about USC 2019 guidelines, LDL cholesterol reduction. How one can go low? How low can be LDL cholesterol? And is there any neurological complications associated with it?
In my deliberation, I did speak and take the topic. I know that how the future questions are going to be. So I addressed somebody, missed it on. So you have to risk aside, and you can go any lower. Even single digit LDL is risk free. So 008, 009 is fine. Many of my youngsters are there, but they had acute MIs and they had already been revascularized. People in this area, I see entire to entire Chhattisgarh joining states. All of them are extremely high and they are young. Unfortunately, clinical planning is lacking somewhere. Suboptimal clinical and preventive planning. LDL is one of the very, very dreaded, robust component in perpetuating their risk. So we bring down LDL to ultra low level. Ultra low level is below 50. Below 50. Don't have to think. This guy is going to be now a neurocognitive decline or mentally subdued, or he will get something. There would be a WhatsApp post coming from some idiot, and this guy, people will listen to him rather than, now they understand that how. And I have to emphasize, and because you have to counter in a very effective visual manner, you have to make them understand that this is how such a statin-like molecule, they are millennial molecule, they prolong life of people and works for their side. Even if, and many people of young people, they improve, we make them improve. Like I won't let anybody die. They come, they are on their job after their ACSs, and these guys resume their smoking, bad lifestyle, mithai khana, pay weight, they gain weight again. But if they are on a proper dosing of statin or say bempedoic on the LDL, it is going to have a hedge against their own risk factor and it still prevent their future recurrent events. So that's where I think you have to bring ultra down to make up for their own risk factor. So 20s, 30s is fine. That's okay. Don't have to worry. What people do, they remove 40 se 10 pe le aayenge usko. At times, if it is enduring, if he's enduring, say for 32 LDL and in enduring for 6 months, I might give him a try. Okay, let not 40 to 20, Zyrova or for 80 to 40, yes. But then not because of a fear of anything, neurocognitive decline or new onset diabetes. New onset diabetes, of course, if you manage, it does happen, but then you have to manage other things too. So art of medicine is very intriguing. You have to be inquisitive. You have to see what patient has come for. You have to also see what patient has not come for.
Sir, thank you so much, sir. This next question is about at what age or at what level of LDL level we start statin or bempedoic acid in congenital dyslipidemia, as we are
Congenital is
detecting
not a
high
wrong.
levels of.
Yeah, congenital is a wrong word. It's an inherited, familial, not congenital. Of course, it's kind of you're born with it, but then congenital is the wrong word. So the doctor is probably alluding to you're born with dyslipidemia high level. So when you started say adolescence, you do it because as I said in one of my all are my slides. Some clear outcome are yours. LDL exposure time. LDL exposure in familial hypertension. If you are homozygous familial hypertension, homozygous is rare in India. Homozygous means LDL 500, 600. You know that. This is horrible. You can't survive, not compatible. And so this is not, I've not seen in India. But heterozygous with LDL 150 and above in 12, 13, 14 years of age, I've seen, and you start statin, right there, no problem. Statin, see weight, if it's coming to the goal, say 100. If there is no other risk factor, goal is 100, not 40, 50 here. It's not coming, azithromycin, or say here I would, because not acute, bempedoic. So your Bemdac comes in the picture. Of course, yeah, same way. Adolescents, young adults, 18, 90, same way. So prevent the high LDL exposure time to the endothelium. You are living with high LDL, you didn't have an event, but you are living with high LDL, your endothelium is getting disease for future. Legacy effect.
That's great, sir. Next question is about, can it be used in ACS patients?
What? Bemdac? Yeah, they've not included ACS patient, but if you say ACS, statins have been used in ACS. PCSK9 used in ACS. Ezetimibe used in ACS. So these three, ACS duration is 1.5 months. So why hurry? You have already three molecules. But if somebody is already had an ACS, you see LDL level, other risk factors, you can continue because there's no side effect. On the flip side, I never mentioned that it perpetuates ACS, worsens, or it gives you arrhythmia and nothing. So if somebody is taking, but in ACS patient, we put 80 mg atorva. We wait for 1.5 months for it. So it's not a hurry. But then somebody is having 192 and it is ACS today, or mid LED plaque rupture, anterior MI, 192 LDL. Probably, yes, I would start with all these three just together because we may not come down to 50 just in 2 weeks. So can be used, but incremental benefit would accrue over time. So ACS would not miss it, but very good question. So it's interesting.
Yes, sir. Next question is about a diabetic patient who is on statin, conceived confirmed pregnancy at 10th week of
pregnancy
pregnancy.
You can't give.
So what are the adverse effects? That's
no.
the question.
Pregnancy is out of question. Diabetes, pregnancy, out, right? So you have to manage. Statins are also out. Yeah.
Yes, sir. Yes, sir. When in hyperuricemia, what should we do? Means if patient is having hyperuricemia, then what one should do?
So subclinical hyperuricemia, uric acid 7, 8, 9, which is okay. I think you have to be watchful of precipitation of acute gouty arthritis or gout attacks. I have not seen it. I have around 30, 40. I have not seen it in spite of high uric acid. I make them understand, be watchful of symptom, not uric acid. It raises marginally and might precipitate crystal formation. But then I'm naive in answering because I'm not seen. I don't talk enough because I've chosen a wrong place here. And so I'm very vociferous of clinical pulse in science. But thing is that I'm from a kind of a smaller relative platform. So I don't speak unless I've seen practically. Theoretically, yes, it does precipitate. You have to be watchful, but it's not an absolute contraindication. So somebody is in acute gouty pain, arthritis, or something, or crystal. No, not required for the time being. And so you have to weigh risk versus benefit. Cardiovascular risk is far ahead of what gout risk is. So you have to first see the severe risk. And if this guy does need, it's a statin intolerant, it does need it. But whatever way it is, पहले gout ठीक कर लो, painkillers दे दो, 10-12 दिन wait करो, allopurinol or your surgical XA and all other things. And then if it all fine, restart it. And man, if he's on hyporesponder for statin, I would rather stop for 3-4 days and then restart it. That's it. But just कि uric acid ज़्यादा है, जैसे आपने पूछा, the way you asked it, you have to be watchful. No other problem. You can still give it unless gout precipitates.
Yes, sir. This is a question from my end. Since right now International Lipid Expert Panel has approved bempedoic acid before PCSK9.
Yeah,
So
that's what I said.
are there any patients of yours whom you have stopped PCSK9 because of cost is a problem? And then
Usually, Satish, good question. And see, the guidelines from ACC is still PCSK9. I told in my conversation, my deliberation, that they are ahead of PCSK9 because they have been used in high risk ACVD patient, acute patient, right? We have three molecules. But forget about this is real one. We're talk of real. Nobody in India is a big researcher that way. If we bring in molecule, you can talk anything in conferences. Real world, I think bempedoic acid is first. Forget about PCSK9 because you and me are not going to afford or to take in an injection. It's an injection. I have, in spite of having 20,000 plus patients, I have only 2 patients on Repatha, right? Now in the era of Bemdac, I think, or bempedoic, I probably yes, the need for it, maybe down, very abysmally low if you rightly prescribe. So why when we have a drug, why? So ezetimibe, bempedoic. No, you know that in Bemdac plus ezetimibe can be combined in a single pill, and or you can have a triple. India में हम लोग जुगाड़ करके बना सकते हैं triple drug in future. So we'll do the trick, right? In over and above you may require PCSK9. जैसे आपने पहले वाला सवाल पूछा, ACS हो गया, थोड़े दिन के लिए हटा लो, एक shot लगा लो. So tips and tricks, no one size fits all. I will take the call when my next patient comes with his all in totality, how economically, mentally, grooming, education-wise, affordability-wise, structural and functional comorbidity-wise, then I take the call. No one size fits all.
indeed, it was a pleasure having you on this evening and talking about Clear Outcomes Trial and CLEARTalk. Any final concluding remarks would you like to give for the audience?
So I'm missing your other doctors of your panels, Dr. Muchala and all. I was expecting him to be here, and say my regards. And good, he's a good learned man. And other people, Mr. Vinay and all, say hi. I'm engaged up in so many other my personal things, so not putting much of attention here. But then I'm very bombarded with the offers of delivering talks and physical. And in era of physical, I'm not able to reach everywhere. So this is still a good medium, and you guys, responsible industry, should continue with this medium, right? And your premium program Inner Circle, you have a good conglomerate of eminent people you bring together. I'm missing on that. And you're a good responsible organ, and you keep the good work up. And all other attendees and my co-faculties and delegates and eminent delegates and August gathering virtually, what I'm saying is that we have to be good clinician first rather than any logist. I'm a cardiologist, but I kindle my physician within in order to keep him very inquisitive and see in totality, because heart, renal system, metabolism, kidneys, everything work in tandem as a team. And these novel molecules that you guys come up and then you release with good quality, with very affordable prices, it's a good service to the mankind. So we have to take responsibility, at least morally, in order the best derived messages from these trials like clear outcome and pass it on to the patient. Otherwise, it will just remain as a talk show kind of thing. So you have to pass it on to the patient.
That's right. Wonderful, sir. I will definitely pass on your message to sir, and definitely will come back to you. And thank you for being with us on this evening, Saturday evening. And the expertise and experience what we have garnered from Dr. Prashant Advani, sir, will definitely help all our delegates in day-to-day practice while treating patients. So thank you, all of you. Thank you, sir. We'll definitely get in touch. So definitely pass on the message to Vinay sir also.
Yeah.
And thanks a lot. Thanks a lot. Thanks a lot.
Thanks, Satish. Bye. Well, my laptop चालू हो गया. I'm just shifting gears. Okay.
Yes. Bye.
Diabetes talk or other thing. Bye.
Yeah.
Nice to have you.
Yeah.
Good night. See you.